Gene therapy in hemophilia, recent advances in gene therapy for hemophilia, clinical trials. Next. Next, please. The faculty will be myself. My name is Annette von Drygalski. I am at the University of California, San Diego, and the second half will be presented by my colleague Guy Young from the Keck School of Medicine of USC. Next. The learning objectives, I will read them out because they are important, is describe the gene therapy correctly, including basic terms and concepts, discuss up-to-date information on the current and emerging approaches for treating hemophilia, including various approaches of gene therapy, recommend appropriate patients for ongoing and emerging trials, appropriately discuss pros and cons of gene therapy with patients and caregivers, including available resources for further education, anticipate short and long-term monitoring requirements, recognize modifications to multidisciplinary care approaches necessary for gene therapy, and identify potential modifications to healthcare systems needed to enable successful integration of gene therapy. Next. The accreditation statement is not so important, but please read through it. This is a CME activity, and it has been accredited in association with the France Foundation and the International Society of Thrombosis and Hemostasis. Next. Disclosure policy, please take a look. We all have to disclose our conflict of interest, as you will see on the next slide. Next. So these are my disclosures and Dr. Young disclosures. Next. I also have to say that none of the therapies that will be discussed are currently available or available for use. They're all experimental and in clinical trials. Next. This activity is supported by educational grants from Biomarine, Freeline Therapeutics, Pfizer, Spark Therapeutics, and Unicure. Next. Let's do a few questions to start. How do you identify yourself in terms of a healthcare professional? Please pick one. What is your area of primary clinical focus? Again, please pick one. Good. So questions during the session, please use the question and answer section to submit your questions at any time, and those will be discussed at the end, hopefully during our panel discussion. Next. So what's today's agenda? I will do the first two parts, which is the introduction to gene therapy for hemophilia, and then updates on efficacy of current gene therapy clinical trials. And then my colleague, Dr. Young, will take over to discuss the safety of current gene therapy clinical trials and also the future of gene therapy for hemophilia. And then we have a panel. Next. So next. Good. So novel approaches to hemophilia therapy. To get the conversation started, one can look at the evolution of clotting factor and other factor therapies through the lens of hemostasis that is represented by the top panel. And you can see here that the conventional clotting factor products cause peaks and troughs, whereby most of the time a trough level of below 1% should be avoided. It's been well shown that anything above 1% reduces in proportion bleeding propensity. And of course, that can be measured by clotting factor activity levels, and you can see the peaks and troughs here. That has somewhat been mitigated by extended half-life factor products. That would be the second part here on this panel. And you can also see the second dotted line here, which is sort of an artificial line demarcating the best bleed protection. Although we have very little data, most experts would say it's somewhere between 5 and 15% of factor 8 or factor 9 activity as the limit above which very little or no bleeding occurs. So the extended half-life factor products somewhat hit that nerve, but you could still see that there is peaks and troughs. They cannot be entirely avoided, although probably very little below that threshold for bleeding. And that can also be measured in the panel below by clotting factor activity levels. Now we come to the non-factor therapies as a means to perhaps abrogate these peaks and troughs and perhaps create more of an environment where there is a steady state, constant protection from bleeding, as you can see in blue here, by constant hemostasis. And of course, since these are non-factor therapies, one cannot measure them by factor levels. This is more expressed in equivalencies. And then we come to gene therapy, which hopefully, or it is the hope, to provide a constant basis for hemostasis that is higher than perhaps non-factor therapies and would sort of be the ideal prophylaxis. And that, of course, can be measured by clotting factor activities, as you can see in the lower panel. Next. Yeah. So what are the elements of gene therapy called the drug? It's a therapeutic transgene, it's a transgene promoter, it's a transgene delivery system in an appropriate host cell, and then transgenic protein outcome metrics. Next. Viral vectors for gene transfer that are currently being exploited are adenovirus, retrovirus, and here gamma retrovirus and lentivirus, and the adeno-associated viruses. All of them are either under evaluation or have been evaluated for hemophilia. Next. The one farthest along in clinical trials are the AAV vectors. They are currently considered the delivery tool of choice for in vivo therapy. They are non-pathogenic. They can transduce dividing and non-dividing cells. However, a limitation of those vectors is the packaging size of the expression cassette, approximately only 5 kilobases and of DNA, and we will see what that means in a moment. Next, please. So let's start with the lower panel, where you see the scheme of an AAV vector, 4.7 kilo single-stranded DNA genome. This would be a typical scheme for a non-pathogenic human parvovirus wild type with little innate immunogenicity. There are many serotypes of those, over 50 with capsid protein variances. And these types of vectors have the property to form stable extrachromosomal episomes. So it's not an integrated vector. Less than 1% is supposedly integrating. And then if you look at the top panel here, you have this vector gutted and the transgene, let's say factor 8 or factor 9, introduced. This introduction can comprise 2 to 5 kbs. For an AAV factor 5 is sort of the maximum. There is codon optimization going on, promoter selection and optimization, and then the inclusion of an upstream intron and enhancers. So let's go to the next slide. Showing you more or less the same. This is a wild type AAV vector. You can see the virus genome on top, and then in essence, it's gutted, and most of its guts are replaced with the therapeutic transgene. There's also an enhancer or a promoter, so sort of promote expression. It's this promoter is liver specific, and it is flanked by these inverted terminal repeat sequences, and they are necessary for episome formation in the cell. For factor 9, the cDNA or cargo is approximately 1.3 kbs, and that's pretty easy relatively, of course, speaking, to be inserted compared to B domain deleted factor 8, which approaches 5 kbs. And there, this blue area, what is labeled therapeutic transgene, becomes very crowded. So it's very difficult to introduce this factor 8 compared to factor 9. Next slide, please. Now, this is a very simple slide showing you how it's supposed to work. So the goal of gene therapy is literally to replace the dysfunctional gene with an exogenous functional gene to cure, that's the hope, the disease. So what you can see here in very simplified version is the gene is introduced into this encapsulated AAV vector. It's intravenously injected, and since the AAV is hepatotropic, it finds its way to the liver cell, where it releases its cargo, and there is episomal expression of now the clotting factor protein. Again, it's not supposed to integrate, and then the protein or the factors are secreted into the bloodstream. Next. So gene therapy in hemophilia is becoming an exciting choice in the field of hemophilia treatment, and clinical trials so far have demonstrated that one single intravenous infusion of an adenovirus vector containing factor 8 or factor 9 can achieve, not always, but can achieve high protein expression levels, relatively long-term durable factor expression, the absence or reduction of spontaneous or traumatic bleeds, and therefore the cessation of prophylaxis regimens in many patients. Yeah, next, please. So now we have a question for you. A patient with moderately severe hemophilia B is 18 years of age with no history of inhibitors and low AAV antibodies. He's on demand for the past 5 years. And so is he a candidate for gene therapy trials? So please pick one. Okay, and the next, please. So I cannot see the poll results or what you picked, but the correct answer would be D. He is not a candidate because he has been on-demand therapy. And that brings us to the short list of the inclusion criteria for most gene therapy trials, which is one has to be male, one has to be an adult, like equal or 18 years, and then with severe or moderate factor 8 or factor 9 deficiency, and the patient has to be on stable routine prophylaxis. So on demand wouldn't count with more than 150 previous exposure days. And then to the right, you have the long list or a longer list of inclusion criteria. Very clear, it has to demonstrate to keep a diary and to keep up with all the study visits, and then also able to provide informed consent. But importantly, and that will also be something to consider for for later true application, and once the products are approved, is the acceptance to use a condom during sexual intercourse for can be several months due to viral shedding. Next, please. That brings us to the exclusion criteria for most, but not all those clinical trials. All of them, though, you cannot have a history of a factor 8 or factor 9 inhibitor or positive inhibitor test at screening. And here, not all, but many exclude for pre-existing immunity to the AAV capsid. And then, of course, in most cases, one has to be healthy in terms of liver disease. So transaminases cannot be elevated. Some trials exclude, but not all, HIV positive patients, and of course, active hepatitis B or C infection because it affects the liver. And the long list, without reading it in too much detail, pertains to bodily organ function. It comes to the liver, comes to the spleen, comes to the blood system, and you can perhaps read for yourself. Next, yeah. So now we come to the updates on efficacy of current gene therapy clinical trials. Next, please. And before we go, we have a question for you. So please answer. Phase 3 results based on at least 42 weeks of post-infusion data for gene therapy trials have been reported for which one? Good. Again, I cannot see how you voted, but I think it's for both, for hemophilia A and for hemophilia B. And so let's start with a listing of the ongoing hemophilia A gene therapy trials. So to the left, you have the sponsor, Biomarine, Spark with Spark 8011, Sangamo Pfizer, St. Jude, Bayer, and then Spark with Spark 8016. So all of them use some form of AAV vector. You heard me say that there are over 50. So some of these numbers are just some of those 50. And then Spark has their own proprietary product. You can see that most of them are still in phase 1, 2, or just now proceeding into phase 3, with the exception of Biomarine, who's probably the one who is furthest along with a phase 3 trial, not only ongoing, but has concluded its recruitment and is well underway to present 2- and 3-year data. So I will not go with you into factor 8 activities because we will see that in the following slides, but just note that in all of those trials, most patients required steroids at some point to mitigate LFT elevations and rejection. Next. So let's begin with the Biomarine phase 3 trial, Generate 8-1 study design. So the eligible participants, as we said, had to be adult males with severe hemophilia A, previously on factor 8 prophylaxis. In this trial, there were no factor 8 inhibitors allowed, and also no anti-AAV5 antibodies prior to inclusion. There could be no significant liver dysfunction or liver abnormalities, and also patients could not have HIV. We are now out actually more than 52 weeks, but the primary efficacy endpoint was a change from baseline in factor 8 activity. And then, of course, with that go secondary efficacy endpoints such as factor 8 utilization rate or the annualized number of bleeding episodes, etc. So next slide, please. And here is the result. After 1 year or 52 weeks, you can see the following in the green bars. The green bars are the interquartile ranges. The diamond represents the median, represents the mean, and the line is the median. You can see, and then you have the minimum and maximum represented by the bars. And what you can see is that over the first half year, there is quite an increase in factor 8 activity, then coming down somewhat in year 1. I think the important point to make here is that the vast variety of factor 8 activities during the whole trial period, with some patients going up into the 400 to 500 range, and some only with a few percentage of factor increase. So quite some inter-individual variety or variability. And at the end of year 1, we had a sort of mean of, or a median of 22, about 22, and a mean of about 41% factor 8 activity. Next slide, please. Now, 17 of those patients went out into year 2. And here in the middle, again, we have demarcated the results of year 1. And then over the second year, you can see a further decrease in factor activity, now with a mean of about 24% and a median of 14%. And again, still this large variability of clotting factor results. Next. So with that, very good. There's a decrease in the annualized treated bleed rate. Very clear, you can see here that post-infusion, a mean bleed rate of 4.8 went down to 0.8, and with that, the percentage of participants with zero treated bleeds increased from 32% on factor VIII prophy to 80% after week 4 post-infusion. Next. As one would expect, this was associated with a reduction in annualized factor VIII utilization and infusion rates. The panel to the left shows the reduction in factor VIII utilization rates in units per kilogram per year. So came down to almost nothing, as you can see. And of course, then that was mirrored by the number of infusions necessary to the right. And that was highly statistically significant. So now we go to the next, which is the Spark 8011 product. I don't have any slides or any result slides for you, but this is the abstract or the gist of the oral presentation at ISTH 2021. And the takeaway points here is that what was presented were results in 17 men, 34 to 52 years old, treated with various doses. It was a cohort dose finding study. And 2 of the patients in the highest dosing cohort did not respond. And in the remaining 15 patients, the mean expression was 12.6 at half a year to a year out, and around 11 or so at 1 year. So the conclusions that were drawn here is that this type of vector or product demonstrated hepatocyte expression of factor VIII that was stable and durable up to 3.5 years following AAV gene transfer, at least in those 15 patients who responded at around a 10 to 11% level of factor VIII. Next, please. The next product is the Sangamo product. And here we have also a cohort study or dose finding studies, cohorts 1 to 4. You can read the number of viral genomes per kilogram provided in these boxes. The largest was 3 to the 13. Corticosteroid treatment, and again, that is very much so for almost every trial, is given reactively if ALT elevations occur. Safety and efficacy data were collected and reviewed by an independent safety monitoring board. And now let's take a look at the results. Next slide, please. So the cohort with the highest, so here depicted are individual patients in the cohort that received the highest dose. And again, you can see how wide the variation in factor activity levels is, with the top patient reaching after about 52 weeks over 150% factor VIII activity, and compare that to the patient in blue who only, on the very bottom, who only reached a few percent. Next. And this is just a different depiction of the same data. I'm using, again, mean, medians, interquartile ranges, and minimums and maximums. Next, please. So now we go to the next Spark variant. That's the 8016 product. It's another phase 1/2 gene therapy trial. Now this product is supposed to be trialed, or the end destiny of this product will be in inhibitor patients with hemophilia A, but this phase 1/2 trial was performed in hemophilia A patients without inhibitors, again, as sort of a dose-finding study. The product used this time a very low vector dose, I presume because of the previous experience with 2 patients not responding due to immune-induced reasons in the first product. It's a B-domain deleted product, and early data are available here on 4 patients and were presented in 2021 at EAHAD. So again, the dose is rather low, 5 to the 11th viral genomes per kilogram. And with that, there was at 52 weeks, we had a range of about 6 to 21% factor VIII activity with no serious adverse events. And again, 3 of 4 patients needed oral steroids. Next slide, please. And this is just to show the relatively low dose given here with the SMART age 016 to the left compared to other clinical trials where higher doses were given. Next. And these are the results by patient. Of those 4 patients, you can see that the patient who did not need steroids is the one with the highest factor VIII expression level of about 20% at approximately 450 days. And the other 3 patients who required steroids are sort of coasting at around 5%, let's say anywhere between 3 and 10%. And below there, you can see the liver function or ALT, AST transaminases. Next. So with that, we move on to ongoing hemophilia B gene therapy trials. And here we have 3, uniQure, Pfizer, and then UCL Freeline. So farthest along is uniQure. It's concluding its phase 3 trial. The recruitment is complete. I should say that 2 of those, including uniQure and Freeline, using the factor IX Padua variant, which is the highly active variant, has about 5 times the activity compared to normal factor IX, and therefore hopefully higher expression levels than if one would just use regular factor IX. You can see the dosing in the tab to the right, and can see that the uniQure and Pfizer study target for about 50 to 60 patients, and UCL Freeline at 18. So let's move on. Next slide. So now let's look at the uniQure product in terms of efficacy and safety. So this trial is called the HOPE-B trial. It is addressing hemophilia B. It uses the Padua variant. Of note, persons with anti-AAV5, so antibody against the AAV5 capsid, were included. HCV patients, oh, can you please go back one? Were also included, but excluded if cirrhosis was present. And then now we'll show you the data on the 54 patients. Please, next. Here they are. So to the left, you have, on the y-axis, you have the factor IX activity. On the x-axis, you have the month. And so you can see out at 12 months, there is about a 40 to 50% factor IX activity present. However, as with factor VIII trials, you can see the wide inter-individual variation from only a few percent minimum to over 100% maximum. But in essence, but very stable expression. Next. So pre-existing antibody titers analyzed at week 26 were not correlated with the response, because that's the natural question. Well, those who have rather low levels, is that because they had higher antibody titers against AAV5? And that does not seem to be the case, as you can see in this graph. On the x-axis, you see the antibody titers. On the y-axis, you see factor IX activity levels, and you can see that there's absolutely no correlation. Now, one patient was excluded because he had a titer over 3,000 and did not respond, which was probably for reasons other than his antibody titer. I think he got a suboptimal infusion dose. But so I think what we can say here that at least up to a titer of 600 to 700, that was the highest titer measured in that cohort, there is no correlation with factor IX response. Next, please. So this comes with a reduction in annualized bleed rates and factor IX usage in the first 12 months post-treatment. In the column to the left, you see the listing of all the types of bleeds treated with factor IX, spontaneous bleeds, traumatic bleeds, joint bleeds. So you can see that in all those categories, there is a significant reduction. And that in the panel below goes hand in hand with a reduction in factor IX therapy usage. So the patients on prophylaxis dropped from 54 to only 2 at between months 0 and 6, and then remained only at 2 at months 7 to 12. And then with that, there's a dramatic decrease in factor IX usage from 250 or so, 1,000 or so units per kilogram per year to only 8,000 units. And for those who are not so familiar with what that means, 8,000 units would be perhaps one dose in one of my adult normal weight individuals. Next. So now we move on to the phase 1/2 gene therapy in hemophilia B by Freeline. It's called FLT180A. Again, we have addressing hemophilia B. We have the Padua variant. As in the Unicure trial, prophylactic steroids. Sorry, I take that back. The Unicure trial had only reactive steroids, whereas here in Freeline, prophylactic steroids plus minus tacrolimus were provided from the beginning. And this was, again, a dose escalation design with 4 dose cohorts. And the idea would be to target normal factor IX levels. In the next slide, I will show you that there is stable, durable results for up to 3 years, that levels in the normal range may be possible. One patient with supraphysiological levels developed an AV fistula thrombosis, and we will see in the next slide how future phase 3 doses will likely be chosen and why. So next slide, please. So here on the left, in the top 2 panels, we have cohort 3 and cohort 4. I won't go much into cohort 1 and cohort 2, which have rather low VG per kilogram levels or in doses. So the top cohort here is 6.4 to the 11th VGs per kilogram. And you can see that with this 2 patients, one had very minimal expression of factor IX, and the other one just goes into the normal range at about 50% after 6 months. But in cohort 2, with an increase, 8.32 to the 11th viral genomes per kg, which is not all that much more. I mean, it's still in the to the 11th range. You can see this jump of all patients being in the normal range above 50%, but then again with quite a wide variation from about 50% to almost 200%. And so the art will be to pick a dose, probably somewhere in between cohort 3 and cohort 4, to raise it to normal levels, but not supranormal levels. But in essence, this product shows stable expression, at least as far as we can tell over the first 6 months. Thank you. Please next. And with that, Guy Young, my colleague, will take over and talk to you about the safety of these trials. Thank you.
All right. Well, so as far as safety is concerned, rather than going through all of the data that is available for safety through each of these products, which gets to be quite tedious, there are some general principles of safety, and we decided that we're going to do that more in a panel discussion at the end. So we'll just go to the next slide, which is just a polling question. The most common adverse event reported for clinical trials of gene therapy is which of the following: infusion reactions, thromboembolic events, elevated liver enzymes, or pyrexia? So go ahead and vote. All right. So as I said, we're going to talk in a sort of panel format. Happy to take your questions, so feel free to enter them into the chat or the Q&A box. I guess the chat box or the Q&A box, probably better. And then we'll be happy to discuss that as we in the panel between me and Annette and the rest of you after. What I want to discuss is moving beyond AAV gene therapy for hemophilia. And so everything we've heard so far from Annette is all about AAV gene therapy. And that's basically all the human trials so far, or up until extremely recently, have just been AAV gene therapy. And there are obviously issues and limitations, as you saw with some of the data. So let's go to the next slide and discuss some of those. But first, another polling question. Sorry, I forgot. Which of the following gene therapy methods involves integration? So integration of the genetically modified DNA into the host genome. Is it current AAV vector mediated transgene, modification of the current AAV vector mediated transgene, ex vivo gene delivery using lentivirus derived vector, or gene editing using the CRISPR-Cas9 system? So yeah, go ahead and vote. And we'll go to the next slide. So I'm going to show you a series of different papers from which I've taken some excellent figures that would have taken me dozens of hours to make myself. So and so some of those I definitely think these are, I read all of these are really actually really excellent papers. Most of these are reviews, or actually they're all reviews. So from this paper, let's go to the next slide. We're going to start with an overall view, let's say the 35,000 foot view. So in the upper left corner, you see replacement therapy. So we're all familiar with that, and you see kind of the history of replacement therapy, and we're not here to talk about that. The panel below that is viral vectors, and it talks about different ways viral vectors can be used. One is in vivo, which is essentially the way that Annette has described the gene therapy using AAV thus far, which is where the therapeutic transgene is infused directly into the patient. The other approach is ex vivo, which is where you remove cells from the body. You then transduce or transfect the cells ex vivo. So you're manipulating the cells ex vivo. And then you infuse those cells back into the patient. So for example, not in hemophilia yet, but in sickle cell anemia and thalassemia, there's been some remarkable results of some clinical trials published in the New England Journal of Medicine and presented at the ASH plenary, I think this past, the last ASH meeting. This is being looked at in hemophilia as well as a possible approach, and there is one clinical trial that I believe is now underway. The downside here is that in order to, and this is using hematopoietic stem cells, and so the downside here is that in order to allow those hematopoietic stem cells, even though they're autologous, to repopulate the bone marrow, you have to do some bone marrow ablation, and that requires some pretty potent chemotherapy. Whether or not that's going to be something acceptable to the hemophilia community as a condition of doing gene therapy when there are other avenues to do gene therapy, I think remains to be seen. And that's all I'm going to say about ex vivo gene therapy for hemophilia, is to say that there are a couple of approaches being looked at. I believe one has actually launched human trials, but that it will require, at least, in some respects, it will require bone marrow conditioning. So that means chemotherapy. That's all I'll say again about ex vivo. So the other group is genome editing. And this is obviously a very novel approach to many therapeutic conditions. And I will discuss that as well. And then the last box is in the upper right corner, I kind of went counterclockwise, is non-viral vectors. So this is just an overview slide. We're now going to dive into a little bit of detail on different viral vectors than AAV. We're then going to also talk about non-viral, not really vectors per se, I guess non-viral vectors and genome editing. So let's go to the next slide. So what are the limitations of AAV gene therapy? Now, I listed a few here. There's probably more than that, but these are kind of some major ones. Many individuals have pre-existing antibodies to the AAV vectors. And we know from many of the trials, if a subject has a pre-existing antibody, they are not eligible. We know that that's not true for all of them. And Annette described the Unicure trial that did not exclude such patients, but all the other trials have excluded these patients. And these antibodies are not uncommon. You're talking 20%, 30%, as much as 50%, depending on which AAV vector and which country or countries that testing or those studies, those surveillance studies were done. So it's a sizable minority at the very least. The other thing is the high vector genome doses that are needed. We look at those numbers, 6 times 10 to the 13th, and that's vector genomes per kilogram. So it's really more like in the range of, 10 to the 14th, 10 to the 15th viral particles. And I think it was Glenn Pearson, I hope I'm not misquoting him, and hopefully he's listening and can correct me later, but where he said that like that amount of viral particles is something like 10 logs, 8 to 10 logs more than the coronavirus infects us, COVID infects us with the SARS-CoV-2 that can cause an infection. Yeah, 8 to 10 logs. So it's a huge viral load. Now, not all of the studies are using E13 doses. Some are E12, some are E11, but regardless, those are really high vector genome doses. And we don't really know, what sort of effects that can have, but it may result in toxic effects. We did see in an AAV trial, not in hemophilia, in a musculoskeletal disorder in children, where the dose was pushed up to 10 to the 14th per kilogram. And I believe there were 2 deaths out of about 4 or 5 subjects. So there does seem to be, those were children, maybe it's different disease, but there's probably is a ceiling at which the toxic effects are going to become untenable. But regardless, we're using huge doses. The third is immune reactions against the capsid. So following infusion, we know that immune reactions can occur. They have occurred, I believe, in every single one of the AAV trials, at least in some patients, and often in many patients. This can result in a few problems. One is the loss of the transfected hepatocytes, which means you're going to lose some of the transfected DNA and have less efficacy. There also may be a safety issue with hepatocyte death, although the rise in transaminases doesn't seem to be all that high, and liver damage seems to be, doesn't seem like there's really liver damage to the patients. But these immune reactions can also result in patients needing to go on immune suppressive medications, either prophylactically to prevent these in the first place or reactively. And we know that immune suppressing medications, steroids or others that are being used or being considered for use, have their own set of side effects. And we've seen from some of these trials where some patients are on steroids for months, tapered, go back on, go off, go back on. And so this is not just, a few week course of steroids to deal with poison ivy or some other type of, immune reaction to a toxin. This is a months-long course often. Then there's the high degree of variability in response, which may be in part due to many issues related to AAV, partly the episomal nature of it, partly these immune reactions, and or transfection capability. So, newer technologies should really also address the variability we see in the responses to patients. And then finally, I think that this technology probably will not work in children. Now, we don't know, but we know children have a growing liver, and we know that they've got, they must have significant hepatocyte turnover. You can't take a 1-year-old who's got a liver that is, maybe the size of a, small piece of fruit like a peach or something, and then end up with a liver that is an adult size that's probably 10 times larger without having hepatocyte turnover. And so I'm not sure that AAV will work in hepatocyte-mediated gene transfer, which is what is being done for hemophilia. As we know that as episomes, non-integrating DNA, which has an advantage in some increased safety perhaps for oncogenesis, but then through mitosis, not all the daughter cells are going to receive the DNA, and that you get a dilutional effect. Now, I am aware that AAV gene therapy is being used in pediatric conditions specifically spinal muscular atrophy, but that's a disease of the motor neurons, and the motor neurons don't turn over, or at least turn over very, very slowly. And so AAV can work there, but in the liver, I'm not sure that it can work because of the hepatocyte turnover that we will see. So there are certainly other limitations. I'm sure some of you are sitting there thinking, well, Guy, you forgot this and this and this. So yeah, there's certainly probably other things as well, but these are, I think, are the major ones. Next slide. So how can we overcome these limitations? So as far as pre-existing antibodies are concerned to things like AAV, for example, where AAV is a ubiquitous virus. So all of us, well, not all of us, but many of us have been exposed to various types of AAV or various serotypes. We don't know it because it doesn't cause disease. So one way around that is to use non-viral transfection. So let's just use things that aren't viruses, for example. As far as the high vector genome doses, we'll need more efficient transfection of the target organ. Now that can be improved with certain AAV serotypes or AAV improved technology, but it may work better using other viruses and using novel techniques such as gene editing. What about the immune reactions? Again, using non-viral transfection or viruses that have very limited immune responses may help. The high degree of variability, we would need to use systems that have more predictable responses, possibly non-viral vectors and gene editing. Now, we don't have data on this, certainly not in humans at this point, but there is some potential that these can give us more predictable responses. And lastly, the inability to treat children, then we would need to use integrating vectors such as lentiviruses or some of the gene editing techniques as well. Next slide. So let's take a look at some of these different specific technologies. So lentiviruses. Lentiviruses are viruses that are derived from HIV. These are retroviruses, but they don't have the capacity to infect individuals. They are RNA viruses, and they're capable of carrying a fairly large amount of RNA, a higher capacity than AAV, which I'll show you soon. The RNA is converted to a cDNA, and that can integrate into the chromosomal DNA. So this means that for dividing cells, such as blood cells, which is why lentiviruses are being used to treat sickle cell anemia and thalassemia in terms of gene therapy, or liver cells in children, the genetic material is passed down to all the daughter cells. So there's no loss or dilution of the genetic material. And that's one reason why lentiviruses are being used in diseases that affect children or in diseases where cell turnover, such as the hematopoietic cells, is significant. Next slide. So let's take a look at this. So here's another really nice review article, and I encourage you, if you're really interested, to dive into this, to take a look at this paper as well. I'll leave it up there for a second, or it'll be made available through some of the websites later on. But the point here is that really a good review for some of these different vectors. Okay, so I think you've had time to write this down. Next slide. So here are 3 viral vectors. So you've heard all about AAV. Adenovirus vectors, they were originally used in hemophilia. We're not really using those anymore, but it doesn't mean that that technology isn't being used in medicine. In fact, you're probably aware that the AstraZeneca and Johnson & Johnson COVID vaccines are adenovirus vector vaccines. So they use actually adenoviruses to deliver the DNA of the coronavirus spike protein. So you heard all about AAV. So just a couple more comments. Notice the packaging capacity, as you heard earlier from Annette, is small, 4.7 kilobase pairs, and it's mainly or almost all episomal. You see it says low inflammatory responses, and that it is low compared to adenovirus, which has a much higher inflammatory response. But it still induces immune reactions. So don't take that low inflammatory response to mean there's no immune reactions. So on the right is a lentivirus. This is can be made as they're naturally RNA viruses. They can be made as RNA or single-stranded DNA vector viruses. They're enveloped, not that that necessarily matters too much, but notice the packaging capacity is much larger, 10 kilobase pairs, sorry. So it's double the capacity of AAV. They do integrate, right? That's the key here. The key difference is this is an integrating vector. So the DNA will integrate into the chromosomes. Now, these have a lower pre-existing immunity than AAV because lentiviruses are not naturally occurring and they are related to HIV. And obviously, most of us have not been exposed to HIV, as opposed to the fact that many of us, 25, 30%, as I mentioned earlier, or more, depending on the serotype, have been exposed to AAV. Here, that number is exceptionally small. They're still poorly characterized in terms of their in vivo effect, and certainly in hemophilia, but we're still learning about that. I believe that, I know clinical trials were set to start this year, and they may have started, I don't know, COVID has pushed so many trials back, but certainly lentivirus vector hemophilia trials are going to be starting in humans if they haven't already started enrolling a few patients. Next slide. So non-viral vectors, so what are these? This is an artificially made compound capable of delivering genetic material to cells. And this would include, for example, lipid nanoparticles. So back to the COVID example, you're probably aware that the Pfizer and the Moderna COVID vaccines deliver their genetic material, the RNA of the coronavirus spike protein, using lipid nanoparticles. So it's not the first time that non-viral transmission or transfection, if you will, of nucleic acids has been done. Next slide. So back to the same paper I showed you earlier. I'll take another figure. Next slide. So again, on the left, you see the ex vivo. I already talked about that. I won't mention that any further. On the right is in vivo, and we have systemic or local, but really we're looking now at systemic administration. The viral vectors I just talked about, and the non-viral vectors would be the other in vivo approach. And you can use either, so far, cationic polymers or lipid nanoparticles. I think that the lipid nanoparticles seem to be the direction that some of the drug companies that are working on this are looking at. Next slide. So what are the advantages of non-viral vectors? So first of all, they're easily scalable production. So you can make a lot of this. And it's funny how throughout all of COVID, I've been able to use some of the information and research and analogies over to the COVID vaccines. Obviously, Pfizer's produced, I don't know, something like 2 billion doses so far, or something like that, of their vaccine. Moderna has made probably half as many, but the point is, you've noticed through the news how much vaccine they can really quickly produce, and that's because these lipid nanoparticles are just, you just need the raw materials, obviously the technology and some very fancy machinery. But if you haven't seen a video of how these mRNA vaccines are made, it's actually pretty cool. I suggest that you take a look at it and how they get the nucleic acids into the lipid nanoparticles and what these little lipid nanoparticles actually look like under microscopes or when enhanced. So the production is easily scalable, and there's a much lower cost to mass production compared to viral vectors. Viral vectors, you need to produce them in cell culture. So as soon as you introduce cell culture, that obviously adds a tremendous amount of cost. The packaging capacity is pretty much unlimited because you can design these non-viral vectors to be as small or as large as you want them to be. So you've got a lot of flexibility as opposed to the viral vectors where there's a fixed amount of DNA or RNA that they can hold. They have very low toxicity. They have low immunogenicity. Humans aren't generally making antibodies against these lipid nanoparticles. Now, the main issue is the poor efficiency to penetrating into the nucleus, and that has to be improved upon. Although, if you look at an ISTH abstract from last year, there was a presentation looking at using lipid nanoparticles, and there was certainly good expression in animals of a factor. So I think that the poor efficiency can be overcome. And then this issue of transgene expression. So for vaccines, it's fine. You just need the immune cells to see start producing some of this spike protein, and then the immune system takes over after that. But I think obviously in hemophilia, we need long-lasting transgene expression. And I believe that that is something that has been shown, at least so far in animals, and probably will be overcome. So I think the last two issues is where technology can really overcome things. Next. So gene editing. So I think of gene editing a lot when I describe this to patients in particular as like the cut paste technology. So gene editing, you can simply add genetic material in an integrated fashion. So that's like basically pasting, right? You can just add this material. You can add and delete genetic material simultaneously. So that's the cut and paste. You cut out a piece of a gene and then you insert something else. And I'll show you an example of that at the end. Or you can also silence genes. And this is why gene editing is really being looked at a lot in a lot of different types of cancer, which are driven obviously by genetic activity. So you can basically go in and essentially cut a gene out and silence that gene. So those are different approaches of gene editing. Next slide. So again, another review article, I suggest that you take a look, and I'm using some figures from this, so I always want to give those authors credit. Next slide. Okay, so at its very basics, the technologies include the following. So you obviously need nucleases because you need to essentially cut the DNA, right? This doesn't work unless you can cut up the DNA and then start manipulating the DNA, if you will. So the three technologies that have been looked at are zinc finger nucleases, TALENs or transcription activator like effector nucleases, or the one that you've probably heard of the most is CRISPR-Cas9, so clustered interspaced short palindromic repeats. That's why we say CRISPR, too much of a mouthful, with the CRISPR-associated protein 9, Cas9. And so this is the technology that you hear about in the lay press. This is the technology that won two outstanding women scientists, including one from here in California, Jennifer Doudna, the Nobel Prize in chemistry. This is the technology that is being moved forward more so than the other two, not that the other two have been abandoned. I'm going to explain in more detail with other figures how this works. Next slide. So these are different gene editing approaches, and I'm not going to get into all the detail here, as I want to make sure we save time for the Q&A. I will show you essentially E, which is the way that we're approaching things, which is the HDR technique, homology-directed repair, and I'm going to show you a slide that is better and more detailed as to how that actually works. But this is just to show you there's a lot of ways that gene editing can be done to accomplish different things. If you're looking on this slide, GOI means gene of interest. So that's the insertion of a gene. Next slide. Again, I'll show you better details. So next slide. Okay, so I'll just say this. If you don't want to read all that many papers about where hemophilia is moving, this paper is unbelievable. I think, I don't know if they made the figures or they worked with an artist, medical artist or animation artist, but this paper has really beautiful figures, not just for gene therapy, although I'm going to use the gene therapy ones, but also for all the non-factor treatments as well. So for those of you interested in the direction of how these new treatments work and to look at some amazing figures, kudos to these authors who are mostly from Indiana, who've done an amazing job on this paper. So I'm going to take one of their figures and chop it up for you. Next slide. So this is just one of the figures, and I broke it into different pieces so that I can walk you through this. And you'll see the full figure at the end. So first, what do we have here? We have a lipid nanoparticle. So here we're using a non-viral vector. And into that lipid nanoparticle, we have put in a CRISPR-Cas9 DNA repair group. So you've got two pieces. You have the Cas9 mRNA, and then you also have the albumin targeting guide RNA. So this is basically just to get the repair, the Cas9 endonuclease, to work where you want it to work. That's why it's called a guide RNA. It's targeting, it's using an RNA to guide where you're going to target the insertion of the gene of interest. In this case, we're going to target the albumin intron 1. Okay, so next slide. Then you have to add the gene of interest. In this case, we have an AAV delivered donor DNA. This is not the same as the vector AAV technology you saw earlier. This is where the AAV is just being used to bring the gene into the same essentially location. as the CRISPR-Cas9 complex. And this is called homology directed repair, or HDR, because what you have here is, notice the AAV delivered donor DNA. Yes, it has the factor DNA in there and the promoter and all that, but you also have those homology sequences, the blue. Notice the dark blue color, the royal blue color, similar to the albumin intron. The analogy I use here, this is like fixing a broken pipe. So you have a piece of pipe that's broken. If you want to fix it right, you should use the same material and the same exact lumen of the pipe and the same thickness of the pipe, right? Otherwise, it's not going to work. So this is essentially like pipe repair, right? So the blue areas are the same DNA sequence. They are homologous. That's why it's called homology. They are homologous to the albumin intron 1. And then what happens is the Cas9 guide RNA complex will go into the albumin intron 1 and cut it and open up the DNA. Then the homologous regions with the cDNA are going to drop their DNA, drop that sequence into that gap or that opening created by the CRISPR-Cas9 complex. So next slide will show you what happens. Or not next slide, but the animation. So there, now you have, here's the albumin promoter, because you're inside the albumin gene. But instead, you've cut out a piece, the intron 1 piece, using this homology driven or homology directed repair. And then you've dropped the factor cDNA into that space. So homology directed repair using the AAV delivered donor DNA, right? So this is different than the AAV actually going into the nucleus and becoming an episome. Next animation or slide, really animation. Then you've got transcription and splicing, right? So now you've got the factor DNA, you've got the promoter, you've got the mRNA fusion transcript, and the next slide, you've got now production of the factor. Click one more time. And there you've got mRNA being translated, and you've got clotting factor production. So this is, using lipid nanoparticle, using the AAV delivered donor DNA, right, for this homology directed repair, using the CRISPR-Cas9 gene editing. And, if you're asking me, and this is just my speculative opinion, but the way that I have read the literature, the way that I see things, I think this is probably the way of the future. Getting away from viral vector transmitted DNA, and I'm not saying that that's not going to work. I think in the foreseeable future, we're going to have products that probably are going to get licensed that are AAV-based DNA that I will tell you that I think they're, really showing some excellent responses. Yes, there's limitations, but some excellent responses. And I imagine I will prescribe those when they're licensed. But I think if we're thinking 5 to 10 years into the future, I don't know that AAV directed in vivo technology is going to be the way that we essentially, hopefully, cure. And when I say cure, I mean normal factor levels for life, hemophilia. I think more likely it'll be this sort of technology. Okay, we're just about at the end. Next slide. So here are the post-test questions, and then we'll have about 30 minutes, a little less, for panel discussion. So the question is, a patient with moderately severe hemophilia B is 18 years of age. He has no history of inhibitors, a low titer AAV, but he has low titer AAV antibodies. He has been treated on demand for the past 5 years. Is this patient a candidate for gene therapy currently in phase 3 trials? So yes, he is a candidate, or no, because he's too young, no, because he has these low titer AAV antibodies, or no, because he's currently on-demand treatment regimen. Please go ahead and make your selection. Okay, that's probably enough time. And then another question coming up is phase 3 results based on at least 52 weeks of post-infusion data. 4 gene therapy trials have been reported for Hem A only, Hem B only, both hemophilia A and B, or neither hemophilia A nor B. Go ahead and vote. All right. Yeah, a couple more post-test questions. The most common adverse event reported for clinical trials of gene therapy for hemophilia are infusion reactions, thromboembolic events, elevated liver enzymes, or pyrexia. Go ahead and give that a vote, and then we'll have one more question. Hey, school has started. That's why we're asking you questions. Okay, and the final question is, which of the following gene therapy methods involves integration of genetically modified DNA into the host genome? Current AAV vector mediated transgene, modification of current AAV vector mediated transgene, ex vivo gene delivery using lentivirus derived vector, or gene editing using the CRISPR-Cas9 system. All right. That one's a little tricky, actually. I'll let the voting finish. And so I think there might be, depending on how you interpret this, I think there could be two correct answers. And on to the final slide. I'm sure that many of you need CME credit. So you can either go to the link or use your phone camera for the QR code to get your CME credit. And if there's any questions, or if you're not getting your CME, you can email Amanda at anoe@francefoundation.com. I'll leave that one up there, and then for a few more seconds so that you can scan it, and then we'll get to the panel discussion. I'm going to open so I'm going to moderate that, and Annette, you can come off mute and camera. Thank you.
Thank you, Guy.
Yeah. So as far as Q&A is concerned, I think why don't we start? I see 4 questions, but let's start with some of the safety that we didn't really touch upon in too much detail. So let me ask you, Annette, you see a few different points there, just 3 there about safety, the recent hepatocellular carcinoma report, steroid use, and post-infusion monitoring. So let me ask you, I know you were a participant in a lot of the work that uniQure has done. Can you give us your thoughts about the hepatocellular carcinoma case, what we know about it, and whether people should be concerned about it?
Okay, yeah, I don't know if I'm allowed to talk too much about it. There's lots of safety concerns going back and forth, lots of communications and lots of reconciliation with the FDA. I think the end result was that that's what the fear was, as we had discussed, the Guy had discussed now extensively, was the integration, despite the fact that it's just an AAV associated vector, and could that have triggered the carcinoma? And the answer is no. So I think that has been put to rest. So there is no indication that there was integration above and beyond what was found in the adjacent normal tissue or in other tissues to lead to that belief. So it was lastly labeled as an unrelated event. But of course, as Guy mentioned, the integration is sort of a fear, and it's always the elephant in the room. And although it's supposed to be very low and not clinically or disease cancer significant, in the end, that is a concern. So I hope that answered it.
All right. Yeah, thank you. Yeah, please continue to enter your questions in the Q&A box, not in the chat, in the Q&A box. So yeah, I think for those more interested in that, there was a ISTH abstract presented. I think you probably can still get access to it if you had registered to ISTH. And that was an abstract that I think Steve Pipe delivered that one, and has some very interesting detailed data. But as Annette said, that this hepatocellular carcinoma case essentially is not related to the AAV vector. I think the data was pretty convincing. I want to ask you one more issue about the safety. So of course we know the transaminases can rise, and I guess for me, I'm not sure how much of it is a safety issue because we're not getting liver damage. I think it's probably more an efficacy issue. But what are your thoughts moving forward about, steroid use? And I know we can spend the rest of the 30 minutes on this, but maybe just give us, a few, major points about the transaminases, immune reactions, and steroids. Maybe just 3 or 4 of your major points about that.
Yeah, I think most trials now, with the exception of one, as far as I'm concerned, is using them reactively with a rise in liver enzymes. And the rise is not what we expect into the hundreds. Sometimes it's just above two times the baseline, which would still often be in the normal range. So that's an adjustment we all had to make. I'm looking out for some who said, oh, it's still in the normal range. Why do we have to worry? But it was above baseline. As Guy said, it's less a safety concern than the trigger to start immunotherapy rapidly to avoid rejection and therefore a decrease in factor levels. And as Guy said, we can discuss until the cows come home what we feel is clinically appropriate or one can recommend in terms of for someone who wants to embark on gene therapy and what is the risk. Current trials say, at least for the factor 8 trials, over 70%, almost everyone is actually subject to some form of steroid therapy in the end, plus minus tacrolimus in some. And for factor 9, for the Unicure trial, that was not the case. It was just, I think, a few patients below 10, 20% perhaps. So quite a difference. Unclear how to interpret that or understand that. But yeah, there are safety concerns for long-term steroid use for starting on tacrolimus. And don't know, Guy, how you feel about that.
Yeah, I mean, I think that this is a real gray area. We've seen trials that use prophylactic immunosuppression. We've seen trials that use reactive immunosuppression. We do see factor levels going down, more so for factor 8 than factor 9, but even in the factor 9 studies, we've seen in some cases factor levels dropping that maybe, or that probably were related to an immune reaction. I think this whole issue is really complicated. And I know that the companies are working really hard in trying to understand these issues better before potentially launching these products commercially. And I think it's entirely possible that by late next year or perhaps sometime in 2023, we may have gene therapy commercially available for hemophilia A and B. Still remains to be seen what the FDA thinks of the data of the trials that are furthest along. But I think how we're going to handle that as an outpatient, for patients with respect to how we're going to deal with the steroids and the the follow-up and when to start steroids. I had one patient, I won't say which trial, but as you said, I had one patient whose transaminases doubled, went from 15, which is pretty low ALT, to 30, which is still normal. And the medical monitor for the trial wanted me to start steroids on that patient. And I said, but his ALT is normal. I said, that just feels wrong to do that. Although the criteria was that if the ALT doubled, I said, if he just, exercised a lot yesterday, or I don't know, he went off protocol and had one beer with his friends, that could have caused that. Anyway, I didn't start steroids on that patient. And actually his next ALT measure a few days later was back down. So who knows why it went up to 30. I think if it's going significantly higher than that, then you probably are looking at an immune reaction. So the whole steroid thing is really, really tough. Well, let's take some audience questions. So I'll start with this one. I think, Annette, you can, if you open the Q&A box, you can see them as well, but let me read it. Can you provide your thoughts on the 9% of patients in Valrox's phase 3 trial that had 0% activity at 52 weeks as presented at ISTH? However, interesting that only 2 patients are back on prophy. So some patients with 0 activity levels are having 0 ABR or low bleed rate. Any of your thoughts about this is appreciated. So I'll start with this one. We'll go back and forth. Well, we all know that ABR is an imperfect measure. We also know there's probably some, I don't say if it's a placebo effect really, because it's not really placebo, but some psychological effect that somebody felt they got gene therapy and they must be better off. And so maybe they're not reporting, or maybe they're feeling like they're not having bleeds, even though their factor activity level is 0. Or maybe their factor activity level is not 0, maybe it was kind of 0 before, but maybe it's 0.8, and maybe that's somehow enough to protect them, from bleeding. But I think that, yes, we have seen a couple of patients in that trial who have had to go back on prophylaxis after some 5 years or so. I think that the levels, the 0%, I think was more than 52 weeks. I haven't memorized all the data, but I think it took longer for many of the patients to drop off far enough to need prophylaxis. But it could be there was one that needed it that soon. I think, this is kind of what I was alluding to earlier about, AAV gene transfer, immune reactions, non-integrating, some of the limitations of AAV may be having an impact here, or it could be specific to that product, or it could be really something about factor VIII gene therapy in general through this technology, where we're going to see decreasing rates. We saw that with the Pfizer Sangamo product as well. I think that we have to wait, really to see the 2-year data for the phase 3 cohort, which is about 150 patients, just to get really a sense of, how often this is really happening and for how long. I'm sorry. Yeah, you mentioned the phase 3 in this question, Margaret. So yeah, you're talking about the patients who dropped off at 52 weeks, correct? Yeah, the 5-year data is showing a steady drop off, and a couple of patients who went back on prophy there as well. Annette, any thoughts on that?
I can maybe, it's one anecdotal patient whom I had was in the first Baxter trial, who was just reported in blood. 9 patients, unfortunately, it wasn't successful, but my patient was the one who dropped after an initial spike on factor 9 back to quote unquote 0. And he was most surprised to hear this, and that his therapy was a failure because he is also completely off prophylaxis. And it's somewhat unexplainable. He's very happy. He doesn't think it's a failure. He thinks that trial is the best thing that ever happened to him. And perhaps, it's on the non-measurable, it's the below 1%. Maybe he's at 0.9. Maybe he was previously at 0.1 unmeasurable. Now he's at 0.9, still unmeasurable, but it helps. He's elderly, he's in a wheelchair. He is not going to play active sports and bleed a lot. So it is interesting. We can't quite explain it, but that's one explanation.
All right, the next question is about the Unicure trial. So Annette, you're going to take this one first. Can you help us understand why with Unicure allowing neutralizing antibodies into the trial and seeing no effect for the majority of the patients with neutralizing antibodies versus all the others, which exclude neutralizing antibodies to a specific level? Do you see how this issue will be resolved, or do you think it's just going to be based on the clinical trial and therefore potentially the specific label for each product?
Yeah, I believe it's the latter. The last sentence applies. As far as I understand it, Unicure initially in their first phase 1/2 trials had just not excluded or had excluded patients by an antibody titer that was done serologically, and then later applied results, and then later applied a luciferase functional assay to determine antibodies, which is much more sensitive, and then detected that, oh yes, there are antibodies here, and saw that these patients responded, and then did decide in the pivotal trial to not exclude those patients. And as we could all see, that panned out really well without affecting expression. And so I think that will go into the label. So a little bit of serendipity and luck up front. That's how that's my understanding.
Yeah, I think I will add that, Unicure, yes, through serendipity, learned that they could probably, quote unquote, get away with this. The other companies who are using, and in fact, the Biomarine trial is using also an AAV5 vector. Now, just because they're both AAV5 doesn't mean they're not exactly the same, I can tell you. But they are, the serotype is the same, but probably the capsids are a little bit different because these are all proprietary and made, by each company. So what I would say is, maybe it could be that if Biomarine had done that, maybe they would have seen the same thing. They just haven't done it yet, although I believe that they have a clinical trial now that they're going to look at not excluding such patients. So yeah, it's another controversial area in addition to the steroids. All this pre-existing antibodies and then post-infusion immune responses and steroids is a really tough area to deal with. And I think you just have to follow the data. So Annette is right. I mean, Unicure showed that most patients, even with pre-existing antibodies, at least up to a certain level, can receive the product and it worked. Now, an important point is there definitely was a threshold effect or maybe a cliff effect, because one patient, the one who had the highest titer, like 4-fold higher than anybody else, that patient had no response. So there is an effect of the antibody up at a certain level, clearly. So there's this threshold effect that was seen. Granted, it's just one patient there, and maybe that patient didn't respond for other reasons. But in that case, I would say, 1 + 1 does seem to equal 2 there. The one patient with the highest pre-existing neutralizing antibody titer to the Unicure product is the one who had no response. So probably there is some effect there, but at the lower levels, that wasn't seen.
So Guy, I think what happened in that one patient was that, so that one patient, I believe that's true, I believe so, had an infusion reaction or some form of reaction that only allowed the infusion of about 10% of the anticipated dose, and then was later found to have that high titer inhibitor. So perhaps that's already related to the infusion reaction up front. No one really knows, but he also just got very little infused. So hard to say what's the chicken and the egg, I believe.
Okay. Next question is, when it comes to gene therapy, inclusion, exclusion, how will the no to minimal alcohol intake done in clinical trials be managed commercially? Well, we're starting to think about how we'll handle things commercially. And I think one of the things that we're strongly considering doing is doing a patient agreement form. It's obvious it's not a consent form because it's not a trial, but we would take some of the information from the consent and basically say, look, I will agree to give you gene therapy if you will agree to the following. And then we'll have the whole list of things, such as the frequent follow-up after the infusion, making sure they show up for appointments, blood tests, all of that, as well as the issues of the alcohol intake and also using barrier contraceptive methods. Even though I think we're not super concerned about some sort of teratogenic effect, but you just never know and we need to be cautious. So if you're asking me how will I manage it commercially, probably we'll have a patient agreement form. And yeah, it's only as good as the person's signature. And if they want to sign it and then do what they want, there's only so much that we can control, right? And we can instruct patients the best we can and hope that they follow those instructions. Annette, any thoughts on that?
No, it's like similar to liver transplant, for instance, where you also counsel the patient to have very little or no alcohol, but then, yeah, it's out of our hands. You can only counsel so and so much.
So for the last technology that Dr. Young believes may be more permanent, is that similar to Megatal tech used by Bluebird Bio? If not, can you give any examples of trials? Well, I'm not sure what Megatal tech is. Maybe I need to learn about that. So I apologize, but I'm not sure what that technology is. What I will say is that last year at ISTH, and you can find the abstract published in the RPTH journal, I believe that's where they published those. There was a presentation, I'm trying to remember the company, is it Generation Bio? I think it was, but in any case, they were using a lipid nanoparticle with something called a close-ended DNA, and I won't get into why they use that particular technology, but they did use lipid nanoparticles in animal models, and they are, I haven't heard anything recently, but I believe their plan is to move that into human clinical trials. In addition, other trials looking at gene editing there's Intellia. They presented some data. I can't remember which meeting, but it's a Cambridge-based company. They've now teamed up with Regeneron, and they have a CRISPR-Cas9 gene editing technology that they have completed their preclinical work, and I think they're working now on developing their human phase clinical trial with the FDA. So that's two examples, one with lipid nanoparticles and one with gene editing. That are moving forward in clinical trials. There's also the lentivirus trial I mentioned, which is out of the center in Italy that developed this. And if I'm correct about this, I believe that they've entered into an agreement with Sanofi to develop that in human trials as well. So sorry, I don't know what the megatal is, but I'm going to look it up right after since I'm so curious to learn about these things. So thank you for your question. Hopefully I was able to give you an answer. Annette, do you know what megatal is?
No.
Okay.
I'll have to look it up as well.
So we've got just a few minutes. Let's move on to one more question. And then if there aren't any further, we can have some closing comments. Can you give your perspective on why there appears to be a slow decline with hemophilia A gene therapy versus hemophilia B, and what the proposed mechanisms are behind this difference? So Annette, go ahead.
I don't know. I don't think no one knows. We can speculate a lot, but I think what is striking and what we should mention and what is of concern is maybe overstating, but this wide inter-individual variety, and that's observed in all trials, and it's hard to predict and tell a patient you will end up at only 2% and you might go up to over 200% or 500 or whatever it is, and then how long will the durability be? So and we don't understand that either. And by the same token, long-winded way, by the same token, we don't understand why one product leads to more decline over time versus the other, which you are right, seems to be more pronounced in A versus B. I don't know. Maybe Guy, you have better.
Well, I mean, of course nobody knows the answer, so I can say I don't know as well. But we can say a couple of things. One is that factor IX is naturally made in hepatocytes. Factor VIII is not naturally made in hepatocytes. We believe it's made in the liver sinusoidal endothelial cells. It's also made in some other endothelial cells around the body, but it's not made in hepatocytes. So in Hem B gene therapy, we are delivering the DNA into the cells that naturally produce factor IX. So that's a difference between Hem B gene therapy and Hem A. Is that the reason we see the decline? Again, we don't know the answer, but you can kind of think like, what if you're forcing cells that don't normally make a protein to make a protein? Maybe they don't like that. Maybe that leads to some apoptosis of those cells. The other thing is hemophilia factor VIII is a much more complicated protein. It has to undergo multiple post-translational glycosylations and folding, as opposed to factor IX, which has some very simple carboxylation. So that folding requires the Golgi apparatus to work properly. And it could be that, again, if hepatocytes are doing this, they're not doing it well. And you may end up with something called the unfolded protein response, which leads to cytotoxic effects and apoptosis as well. The other part is that in Hem A, because the gene is large, we're not inserting essentially the full gene, right? It's a B domain deleted gene. Now, we know in the final protein, the B domain has no function. That's why we have B domain deleted factor products on the market. But maybe the B domain is important in the going from transcription and translation into the final protein. Maybe it is required for proper folding or things like that. And so, to think that a large segment of DNA in a gene like factor VIII has no function, I don't know. I believe in evolution, and I think, well, why is there this big B domain if it's not doing anything? It must, in my opinion, must be doing something. And so maybe we'll learn what the B domain function is through this. And so that's another difference. The factor IX gene is placed whole. Granted, we put the PADRO mutation, but that's kind of on purpose, but it's otherwise the full factor IX gene. So those are differences between Hem A and Hem B gene therapy that those are all true. Those are all real differences. Now, is that why we see a decline in Hem A and not so much in Hem B? Of course, that we don't know the answer. All right, last question with 3 minutes left. I imagine the HTCs in the US are having conversations with their regional, national payers on reimbursement for gene therapy. I'm hoping there'll be some solution for reimbursement for the spoke or local HTC for monitoring if the US follows the hub spoke model that has been published. Well, I don't know. Yes, I mean, there's been publications that we should have a hub and spoke model. I think that we'll figure that out as we go. I mean, can all HTCs or centers that even care for hemophilia that are not HTCs perform gene therapy? Let me just say that having done gene therapy in several trials now, that once it's commercialized, it's not like writing a prescription. Okay, it's not like Hemlibra, new drug, write a prescription, a pharmacy fills it, you teach the patient how to give it, and and it's all done. Gene therapy is much more involved. First of all, you're talking about using a genetically modified organism. So you have to go through some sort of biologic safety protocol. Institutions often have these biologic safety committees that will give you approval to use it, and with caveats on how to use it and safety measures that have to be in place. So, that's one aspect. And obviously you need to have an infusion center that can infuse this product and be ready to respond to reactions. I had one patient, I won't say which trial because I try to be confidential about these things, but who had a pretty wicked anaphylactic reaction when we started the infusion. We had to nurse him through the infusion. We were able to do it. He went home the same day, thankfully, but you have to be prepared. It's not, you can get these things with factor 2, rarely, factor 9, not super rare, but rarely. So yeah, you have to be prepared as a center to do that. How the financial piece plays into this, I don't know. I don't know that we're having conversations about, how do we think this will look and what will the model be? But ultimately, how this is going to work out, I honestly don't know. My bigger question is, am I going to be able to generate revenue off gene therapy? If I take a patient of mine who's on the 340B program, who is on a $500,000 a year factor, for which I get 20% overhead, just for example, I'm just not saying that's what happens, just as an example. So that's $100,000 a year. And over 5 years, it's $500,000. And then he gets a gene therapy product, and now he's not using any factor. So I've now lost $100,000 a year. Am I going to be able to get a reimbursement or a cut of the payment from gene therapy for that patient that will ease the pain or maybe take away the pain of losing that money over, year over year? I think that's a bigger question for HTC sustainability as gene therapy moves forward. So we're at 5:30, so I'm going to stop. I will pass it to Annette because I don't like to always have the final word, and I just talked a lot. Annette, any final thoughts on that, and then we can stop.
No final words other than thank you for joining us all and learning with us, because we all keep learning as this goes along. And and thank you, Guy, for a wonderful presentation on the outlook of gene therapy and new forms of treatment. And on we go.
All right, thanks everybody. QR code is up there again for those who are late arrivals or just joined if you want to get CME credit. Thank you also to Amanda Noe of the France Foundation, who helped organize all of this for us and for you as the audience. And with that, I hope you enjoy the rest of NHF. Take care.